Okay, so you think you're ready to start? Okay, very good. Stay on the phone so we can make sure we can get the share screen. Okay, so you think you're ready to start? Okay, very good. Stay on the phone so we can make sure we can get the share screen. Okay, are you ready, John? So, you think you're ready to start? Okay, very good. Stay on the phone so we can make sure we get the share screen. Yes. Repeat. 8. Okay, are you ready, John? So, you ready to start? Yep. Yes. Okay. Repeat. We will wait for folks to connect. I'm going to go ahead and put you on hold there, John. And we'll just go ahead further conversations with you by text, all right? Thank you. Yep. Yes. Okay. We'll wait for folks to connect. Go ahead and put you on hold there, John. And we'll just go ahead and further conversations. Okay. All right, we'll get the ball rolling. I think we may have everything working now. Apologies for all the difficulties that we find ourselves in tonight. Unfortunately, we're not at the university. I'm actually in a different location, and this is very difficult for us to try and coordinate from afar. Circumstances require that we find ourselves in this predicament. So apologies, and this will be also on YouTube, hopefully without the feedback. And also, if you have any questions, please let us know. All right, well, let's get the ball rolling. Okay, the presentation obviously it has to do with psychotherapy, and we're going to focus a great deal on that. There are approximately 97 slides. I want to go into detail as fast as I can because there's a lot of really important information. However, let me start off by, as I always do, emphasizing that there are a lot of organizations that supported this work. Obviously, the most significant group has been the American Psychological Association. Very pleased that they have been supported right from the very start. But I also need to also emphasize the support of other groups. And in addition to APA, AMA has been very involved in making sure the psychology is at the table, so to speak. A lot of people have been behind this. I want to acknowledge several. Uh, the most important person within APA at the particular time is Randy Phelps. Encourage you to follow his work in his new position. And of course, the CEO, Norm Anderson, has been very, very supportive of this work, as has Catherine Nordell from the Practice Directorate. Outside the APA, let me emphasize the work of Jim Georgialakis, who actually is the person involved with the AMA CPT RUC side of things, and Neil Pliskin, who has replaced me on the panel advisory group, and I'll talk about that in a second. There's lots of people that have contributed, although most of it has not been financial, and the slide indicates that. It's important for you to appreciate the fact that AMA, and for that matter, APA, does not support this financially. They do cover expenses, or at least AMA does. APA used to. I've been involved in doing this work for a long, long time, and some of you know that because you've heard me before, but there may be some newbies here. I've been involved since approximately the late 1980s when I was president of the North Carolina Psychological Association, and since about 1992 with the AMA on the current procedure terminology group, which I'll discuss in a few minutes. But there's many other things. Probably one of the more interesting ones, and one that's not often related to at least publicly, is my appointment on the Medicare Coverage Advisory Panel back in the 90s, as well as the model policy that was put together about 20 years ago. It's important to emphasize that everything that I say is aspirational and should not go against the APA Ethics Code, which I was very lucky to have been part of the ethics panel as an associate for a number of years. And of course, HIPAA, other federal regulations, as well as state and province regulations that you have to live by. One of the most important things, however, that I can share with you tonight is the next point, and that is be careful about the contractual agreements that you participate in, because those turn out to be major, major issues. And as I'll say on a number of occasions this evening, in essence, this is all about what the insurance company thinks in some ways more so than what you think. It's critical. I wish it was otherwise, but all things being equal, turns out to be a major concern that we need to be aware of. So with that in mind, let's move on to the issue of great importance today, and that's the current procedure terminology. This is the overview. And I'm going to talk about some of the issues in a very broad strokes and then get into detail really very, very deeply, more so than I usually do, because I'm just talking about psychotherapy just tonight. That's just the primary focus. Actually, to be honest with you, the only focus. So let me start by saying that this material is copyrighted by the American Medical Association, under license by the Center of Medicare and Medicaid Services, and this information can be ordered from the AMA, and the number is found there, as well as the website. Okay, so let's talk for a moment, as I have previously, what's a CPT code? In fact, I'm actually at a facility outside of my state, and I was trying to explain to the staff what a code was, And I said, this is actually the number that you circle to get reimbursed for whatever services that you do. This is something that everybody seems to understand. A couple of things worth mentioning. It's something that healthcare providers do frequently, that there should be some empirical support. And in addition to that, there has to be something that theoretically is applicable in a wide range of settings and a wide range of locations. The American Medical Association started this in 1966, primarily by surgeons and subsequently by other physicians. And at the present time, it's involving about 8,000 discrete codes. The group, the panel, which I'll describe in a second, is made up of a number of professionals that meets 3 times a year, usually in very nice locations, thankfully so. But I have to be also honest that they give us these wonderful venues to meet, and then they don't give us the opportunity to enjoy those venues. The 8,000 codes that I just referred to you a few minutes ago really apply to a wide variety of medical and health procedures. And to be brutally honest, not everyone has a wide range of options. As a matter of fact, in the case of psychology, depending on how you view things or what state you might work in, what kind of license that you might have, we're talking about 50 or 60 codes total. And the codes are broken up in different categories: psychiatry, biofeedback, central nervous system assessment, physical medicine and rehab, health and behavior assessment and management, team conference, and evaluation and management. Historically, we lived almost exclusively under psychiatry codes. Matter of fact, that's indeed how we lived until relatively recently. We added the central nervous system testing codes back in the 90s, the health and behavior code about 10, 15 years ago. And for what it's worth, those are going to be addressed another time, and we're revaluing those. So if you get the opportunity to participate in a survey for the HMB codes, please consider those. Now more than ever, we're moving into other areas: physical medicine and rehabilitation, team conference, and of course the holy grail for a good portion of healthcare, and that's evaluation and management. But today we're only going to be focusing on psychiatry, and specifically the so-called mental health codes involving psychotherapy. So in essence, what we have here is 3 types of codes. What I call the psychiatric or mental health codes were started in the 1970s. We seem to have some difficulties understanding exactly when those were made available, but it appears to be about that time. The neuropsychological testing codes, which I mentioned to you just a few minutes ago, the health and behavior codes, and of course the new evaluation and management codes, and for that matter the wonderful sort of pioneering opportunities that lie ahead with the telehealth codes, which I'll address with you this evening, at least very briefly. All right, so again, we're going to stick with the psychiatric codes, and for another day, another dollar, so to speak, we'll address the neuropsychological and health behavior codes at a later time. Okay, so let's start by addressing this very simple question, which obviously seems ridiculous to you and I, but let's make sure that we understand it, and that is, what is psychotherapy? And you can see from this slide, psychotherapy is a treatment for mental illness and behavioral disturbance in which the clinician establishes a professional contract with the patient and through definitive therapeutic communication attempts to alleviate emotional disturbances, reverse or change maladaptive patterns of behavior, and encourage personality growth. Now, let's kind of take a look at this. This is a couple things worth mentioning, okay? First of all, the big one is that we have a mental illness, okay? And the mental illness is really the if you will, the limitations of what we can work in. And in essence, we do not deal with medical illnesses or for that matter, any kind of neuropsychological or neurological illnesses. Okay, excuse me a second. And in essence, there's some kind of relationship that goes on. This case is called professional contract, and there's a therapeutic communication that attempts to alleviate emotional distress, reverse or change maladaptive behavior patterns. So in essence, it's about mental illness, it's about therapy, and you are trying to attempt. This is a critical point. Attempt, not necessarily result. And will become a big issue as time goes on because we're moving into a situation from fee-for-service to fee-for-performance. And we'll have to remember that the focus is on attempting, not necessarily alleviating. All right, so a quick side point. This is an issue that I think bears some discussion. Let's talk about incident 2. Incident 2 is feasible, assuming the psychologist provides direction and regularly involved in the care of the patient. Now, let's stop for a moment. What's incident 2? Let me give you an analogy. It might be the easiest way to explain it for you. Number one, a physician, and this is a standard example. A physician actually ends up providing a service. For example, you have a particular activity, such as physical. And during that time, the nurse provides some additional support. For example, they take your blood pressure, temperature, weight, and so forth. That is actually incident 2, the physician. So it's actually billed under the physician's name as if the physician did the service. And in essence, this is the critical issue. And the reason I say that is because the assumption is that it's the physician that's actually responsible for the service, and it's sort of subsumed under that. The question that some people have brought up is, can a psychologist, or for that matter, a psychiatrist, provide incident 2 services? In other words, could I hire a bunch of social workers, have them do psychotherapy, and then for me to sign off as if they were doing that? Well, the answer is it depends. First of all, how you do this. And then second of all, whether the insurance company allows it. First of all, incident 2 is not hiring a whole bunch of people and having them do their own thing. It means that you provide direction and you regularly are involved in the care of the patient. So for example, you might tell someone else, you need to do cognitive behavioral psychotherapy, focus primarily on depression, reduce the following symptoms, and then have the patient come back to you, say 5 sessions later, and you make the decision as to what to do with the patient. It is not having someone else do psychotherapy from beginning to end, and in turn having no information whatsoever what's going on and just simply signing off. That's not incident 2. That is essentially is what we might call fraud. So as a consequence, you have to be extremely careful what you're doing. That's not incident 2. That's quite different. And I believe, just my own personal opinion, that very few people actually do incident 2. Most everybody is doing who knows what. So with that, let's talk about the psychotherapy codes. The psychotherapy codes, in essence, came into being in 2013, and now are in full force. In essence, that means that, there is no way that you can do anything but what we have available at this particular point. All right. So, what is it that's going on? Big changes in the interview and in the actual psychotherapy itself. And as you can see, the primary issue is time and intensity. The whole concept is to make it more granular. All right. Let me explain. Every 5 years, CMS decides what codes it needs to be reviewed. And they decided some time ago that the psychotherapy codes needed to be reviewed. So in an effort to do that, CPT, which I'm actually on the panel, I'm not an advisor like I was, that's Neil Pliskin's position, requested that a small work group be convened. And that group met through 2010, 2011 to give the charge for a larger work group that met 2011 and 2012. The original panel planning work group involved essentially myself, 2 psychiatrists, I believe, one other person. And our job was to tell the so-called planning work group, here's what we want. And the difficulty associated with that is essentially that we did not believe that the type of psychotherapy that was being done today reflected the type of psychotherapy that was found in the workbooks, or that is the CPT panel, a book that's published every year. And in essence, when we actually decided to redo this, the goal was to modernize the codes. The eventual advisory work group, which is really the one that's, if you will, more public and so forth, so on, included nurses, psychiatrists, psychologists, and social workers. An internal work group was also convened by the APA, and that was led by Randy Phelps. And since that's an internal work group, I won't share the members, but I will tell you this, that it was a stellar group of individuals very committed to try and making the new psychotherapy codes much, much more up to date. And in essence, to do this, we had recommendations from a variety of sources, but the real focus, as you can see from this next slide, is that we wanted increased viability, in other words, making codes that were useful, and accountability. Interestingly, there was no bias theoretically proposed. In other words, it was not biased towards psychology, towards psychiatry, and the focus was consensus. In essence, we didn't vote, or at least that group didn't vote because I was not part of the work group. It was theoretically people came to understand as a group. And I have to be honest, again, this turned out to be a lot more difficult than people ever anticipated. And the reason for that is that some people just did not play as fair, at least from the outside perspective, as I thought they should. These are the individuals who had representatives. As you can see, psychiatry is heavily involved here. But again, these folks are part of the AMA process, and as a consequence, they have a delegate. The last time this was done was, about 2 decades ago, and we had 27 new codes, 9 code revisions, and 8 code deletions. This go around, we have 11 new codes, 4 code revisions, and 27 code deletions. So in essence, we end up with a significant change. I would say if this is not the largest change, you can see it's actually not in terms of volume, it's the largest change in terms of paradigm. And here we go. So in Tucson, in February 2012, the panel accepted several things. The first, and it was to me a huge surprise because it was brought to the panel as the number one issue, or the first issue, I should say, not necessarily number one, the establishment of a code for pharmacological treatment, and then the revision of psychiatry guidelines, deletions of codes, addition of others, and I'm going to go into some detail. So, the big one is the change in the psychiatric diagnostic interview, and the second big one is the most frequently used psychotherapy codes. So, this is a big issue. This next slide is a complicated issue for many, many, many reasons. First of all, we have at this particular point only 3 times, 30, 45, and 60. We are working on a 90, but this is a mistake that's based, oddly enough, on the fact that the only available data, available to us anyway, on the use of psychotherapy was the Medicare data. The reason for that, all the other insurance companies, that's private information, and we did not have access to. It turns out that even though there was a 90-minute code, in the original psychotherapy data set, that code is rarely used by Medicare patients. So it's very difficult to propose to a panel that's basically empirically driven that indeed we need to consider having a 9-minute code when in reality it just wasn't happening at all. And as a consequence, we ended up with 30, 45, and 60 because there was data to support those. Now, having said that, I want to emphasize one more time the issue of intensity. Intensity was really ended up with 2 levels. Let me explain this in this next slide. When I put this together on the original work group, the idea was as follows. I believe that, at least in my own mind, there was probably 3 levels of intensity. There was what I call the counseling experience, often experientially based. Secondly, there was the standard experience, which is what you and I might call empirically based psychotherapy. And there was a complex experience, which is the kind of experience that you might have when you have a crisis situation. To be honest, what I was trying to do is trying to establish a E&M, or evaluation and management, triple level. In fact, we discussed the idea of a 5-level system, which allowed for different kinds of complexities to be involved. In other words, it just didn't seem like one psychotherapy fit everything. There was different kinds of psychotherapy, and I wanted to make sure that they be covered. Some seem very easy, and some seem much harder. With that in mind, I wanted to propose that. Now, the original idea was to propose it according to discipline. However, discipline-specific codes are not kosher within the system. So we ended up deleting that, and we went the idea that at least there's 2 levels that could be easily identified: standard interactive complexity, and if you will, as you'll see later on, there is the so-called crisis code. All right, so let's focus a little bit on psychiatric interviewing. Do you see in a psychiatric interview that we have the so-called 90791 to report psychiatric diagnostic evaluation and integrated biopsychosocial assessment, including history, mental status, and recommendations. The evaluation may include communication with family or other sources, and review and ordering of diagnostic studies. This replaces the old 90801. Now let's tackle this a little bit. First of all, it says integrated biopsychosocial. So it's really a mishmash of whatever. Number 1. 2, it is history, mental status, and recommendations. That is the bottom line if you ever get audited. You have to have at least those 3 things. It may include, this is a very new radical idea, communication with family. This is something that we did not have historically, we now have at the present time. And by that I mean we have the opportunity to try and gather collateral information, which we historically couldn't do. We could, before the 90801 was a singular non-time code. This one, as you see, turns out to be very robust. For those of us who have the opportunity to do prescription privileges, 90792 applies to you. If it doesn't, then, which is actually probably most of us, is 90791. As I mentioned already, history, mental status, review, an order of diagnostic studies, and recommendations. These are the basic things that you should have in an interview. As you can see from this one, 90791, and its companion is actually 92, excuse me, do not include psychotherapy services. This is just diagnostic interview. And includes examination of the patient, exchange information, or in lieu of the patient, other informants. This is really, really critical. You appreciate this point, that unlike the other code, you can interview more than one person. Historically, we couldn't do that. In this case, you can do that. And the following. Reassessments are permitted on different days. So you can do multiple psychiatric interviews, and you can report more than once when separate interviews are conducted. This is now a super robust code relative to the old 90801. If you're doing an interview, please consider the following: past psychiatric history, chemical dependency history, family history, social history, treatment history, and medical history. This appears to be the basic criteria required to pass an audit type of activity. All right? You do a review of the systems, safety, lethality, aggression, and competency. In fact, just all things being equal, you could actually construct, if you could imagine this, an interview form that contains this data. The data is found on slide quote 7, and again slide 8. Notice that you can get this from mental status, and you should include a diagnosis, which involves the actual diagnosis, the DSM, personality, contributing medical factors, psychosocial stressors, and current level of functioning. So, in essence, this gives you a rough idea of what you should pursue, followed by a treatment plan. What is it that you're going to provide or suggest to the patient? Includes consideration of medication, psychotherapy, tests that you might do, level of care, and informed consent for treatment if you are going to pursue that yourself, and what is the disposition to or with the patient. All right, so again, 90791, psychiatric interview without medication management, and 92 with medication management. Now, let's shift our focus and talk for a few minutes about psychotherapy itself. Could very well be that this is the focus of or the reason you're in this evening's presentation. With the psychotherapy paradigm, notice again on the left-hand column that we have 3: standard, interactive, and crisis. In the time of psychotherapy, we have 30, 45, and 60. And appreciate the fact that you can have standard psychotherapy that's brief, regular, or extended. Interactive psychotherapy is 30, 45, or 60. In crisis, very limited in many ways. It's 30 to 74, and for every additional 30 minutes. We will talk about each of those in great detail. Again, this is the definition of psychotherapy. Not very different than what I described for you earlier. All right, so what about these new psychotherapy codes? Which at this particular point, they're not so new. First of all, there's no need for having inpatient or outpatient codes. They're all the same. And we will not use interactive psychotherapy. Instead, there is a new add-on code called interactive complexity, which is found under the rubric of 90785. And again, we'll discuss this in some detail. The psychotherapy service codes 832 to 837 include ongoing assessment and adjustment of psychotherapeutic interventions and may include involvement of other family members. The patient must be present for some or all the service. So, what does this mean? This essentially means that unlike the prior psychotherapy code, you are allowed to involve other people. And it could very well be that the involvement of the primary focus, for example, the patient, may be very limited, 1 minute or 2 minutes. And the actual time turns out to be the other significant other involved in the concomitant psychotherapy. Codes 832 to 838 describe time-based face-to-face with the family and or the patient. So let's discuss this for a moment. Psychotherapy, unlike testing, which we'll talk about next month, It's all about face-to-face only. You cannot bill for activities away from the patient. The code is based on the one that's actuals to the closest time. In the case of 30-minute psychotherapy, you cannot bill it unless you've done at least 16 minutes worth of therapy. Anything else will be totally unacceptable. All right, let's operationalize this. 3-2 or 30 minutes is anything between 16 and 37. 3-4, 38 to 52, and 3-7, anything over 53. Couple of caveats. It is assumed that the standard psychotherapy has always been 45 minutes. And it is assumed further that the current psychotherapy that's considered standard continues being the 45-minute. Shifting codes because of reimbursement may not be in anyone's best interest. Here we go again. 30, 45, 60. We will have a solution in the works for the 90-minute activity in the very near future. We've been working on it ever since we discovered the mistake, and at this particular point, we believe there may be a solution. All right, so a couple other things. Site of service is no longer recorded. So, as I mentioned, the same reimbursement, same code is used for inpatient and outpatient. Now, what is involved in inter-service, that is, the service provided to the patient? Objective information, interval history, examination of symptoms, metastatus changes, current stressors, coping style, and whatever psychotherapy you use. One thing that may be worthwhile, keep in mind that this information is what is considered to be acceptable by CMS and, for that matter, AMA. So as a consequence, as you're putting together your own, if you will, record, it may be of some value to use this information as a foundation for your medical record, or, if you will, psychological record. All right. In terms of 90837, use that in prolonged current service code. However, keep in mind that we have a solution coming up for you very soon. This is a summary of the different things that I mentioned so far. Most of us are not going to be doing evaluation or management, so we're looking at 3-2, 3-4, and again, if you will, 3-7, which we'll talk about in very briefly later on as well. All right. Now, this is an issue of great concern. Some people are not sure what interactive complexity looks like. This is intended to mean that you're having to do something more with the patient than average. So let's talk about what that may be. First, it's an add-on code. The code is 90785. All right, let's look at it. Interactive complexity refers to specific communication factors that complicate the delivery. Common factors include difficulties with communication, discordant emotional family members, and so forth, so on. Let's look at this slide. This is, in many ways, the bottom line. If you have one of the following four things, interactive complexity should be used as an add-on. Is a maladaptive communication so problematic that you have to go the extra mile? The patient doesn't want to be there, so you have to explain it to them. Maybe you have to engage in some rapport building and so forth. 2, caregiver emotions or behavior that interferes. The patient doesn't mind, but the significant other doesn't want them to be there. Evidence of disclosure or a sentinel event. In a psychotherapy experience, for example, you realize that you have to report this to the nurse as something is going on, they're tonguing their pills. That requires a sentinel event documentation, so it makes it interactive complexity. And finally, the use of equipment, including interpreter translator. This actually was in a listserv recently. You can use a translator, but all you're going to get, in addition to your basic psychotherapy activity or reimbursement, is a minimal add-on. So it does not necessarily mean you're going to get $15, $30, $50, $100 extra. All right. It may involve family, may be reported more than once, and the service reported only once per day. Let's step back, because I now have told you about two psychotherapy codes, what I call basically your standard code, and secondly, what I call your interactive code. Now let's go on to the third. That's what we call the crisis code. The crisis code is provided to a patient in a crisis state, reporting with the codes 90839 and, or for that matter, 840. Well, I shouldn't say or. It depends on the circumstance. You'll see that. May not be reported in addition to psychotherapy. You don't necessarily do this in addition to psychotherapy. You do this in lieu of psychotherapy. The presenting problem must be life-threatening. The treatment involves a bunch of things: psychotherapy, mobilization of resources, diffusing crisis, restoring safety, and so forth. The service may report it even if the time spent on that date is not continuous. So you can do it 2 hours in the morning, 1 hour in the afternoon, and so forth. The time for the that's involved in psychotherapy, the individual can devote, or I should say should devote, the full attention to the patient. It's not like you can do this and do psychotherapy on someone else. This is it, the only thing you can do that time. And the patient must be present for some of the service, not all of it, and does not have to be continued within the date of service. 39 and 840 are reporting the total duration of time. Total duration, not just in bits and increment, the total duration. So it can be 2 units, 5 units. The presenting problem, again, is life-threatening, and you should do an urgent assessment involving a crisis state, a mental status examination, what are you going to do. In all fairness, the process for the documentation is really easy for this code relative to, for example, psychiatric interview. Okay, these are time-based codes. 39 is a foundation or base code. You report this once. You have to have at least 30 minutes. If you don't have 30 minutes, you don't have a crisis, so to speak. And then after 74, you jump into 840, and the add-on code is for all the extra time in increments of 30 minutes. Okay? So the original base code is 39. The subsequent add-on codes is 40. All right. I'm going to pass through these relatively quickly because there's nothing new here. These are old codes, but I'm just kind of going over them so people are aware of. These are for family psychotherapy, and family is not defined, if you will, in the traditional sense. It's more, quote, in the modern sense. And these are 46, 48, 47, and 49. This is with a subsystem or a family, like, for example, a couple or even several people. All right, 46 is report service when the patient is not present. Word to the wise, almost nobody reimburses 46. 47, a report service that includes the patient some or all the time. This is relatively new. The whole idea that you don't have to have the patient there all the time. And you have multiple groups, if you will, multiple subgroups, you would report 49. This is essentially unchanged. What about group psychotherapy? And when there's no family unit per se, but a common theme, for example, PTSD. Code 90785 could be used in conjunction with 853 to report a group psychotherapy code. And I might point out to you, this is a new issue, altogether new, and that is you can include interactive psychotherapy. And again, it's for the basic code is 53. Interactive psychotherapy is the add-on code of 785, which would be used on top of the original 53. For those of you that work in certain locations, such as Louisiana and New Mexico, keep in mind that this code is new. This code is actually the one that was most problematic for the American Psychiatric Association. Well, from my perspective, of relatively little problem to the American Medical Association. As you can see, this is a 90863, which captures pharmacologic management, including prescription and review of medication performed with the psychotherapy service. So you have to do psychotherapy and provide a prescription. For this particular event, okay, if you're a physician, you should use the evaluation and management codes, and the codes are found in this particular slide. Okay, let's talk a little bit about psychotherapy with a non-patient. Sometimes you may be in a position to want to get information or affect change by involving non-patients. You can spend individual time with those people, and of course keep in mind that if you do so, you have to document it. All right, so a quick summary. Here's the summary of the actual slides. You can see the different codes on the left-hand side and the code descriptors on the right-hand side. This might be a good cheat sheet for you to have in your office. If you're wondering about the RVUs, here they are. This is how the codes are valued. Notice that the psychiatric interview code of 791 continues enjoying a very high level of RVUs because the amount of cognitive work associated with it. And psychotherapy at 30 is 125, 45 is 160. And notice, by the way, that the 60-minute psychotherapy is not that different than the psychiatric interview code, and for that matter, that the interactive complexity is relatively small. I might point out at this particular juncture, 39 and 40, which is the psychotherapy crisis codes, are not priced at this point at the national level, and I think they will be soon. And the pharmacologic management code still has a long ways to get acknowledged by CMS. And this information includes found in the final fee schedule, which is the actual references found on this particular slide number 64. All right, so here's the issue of payment. The individual psychotherapy is probably about 1 to 5% reduction, and the RVU for the psychopharm code is actually 0.48, but it was not accepted. And we thought at one point the group psychotherapy codes would be going to be reduced, but it turns out that they were not. So we have the psychotherapy summary codes, and you see that in this particular slide. You have the interview, the psychotherapy, and the crisis therapy by interactive complexity and the so-called psychopharm management code. So another way to envision this is that the interview can have interactive complexity and psychotherapy can have interactive complexity. So code 90785 is a very robust code that can be added to interview or actually psychotherapy interventions, whether it's 30, 45, or 60. We have new interventions, which is psychotherapy crisis, and the psychopharmacological management code. These are all very new. Another way to look at this is to consider the following two slides, which describe in detail how these particular codes would work across certain scenarios. All right, so what are the big issues? All right, let's talk about the three, or two, as far as I can see. First of all, is the fact that 60 minutes is not, just for whatever reason, it has not been well received by some insurance companies. It's important to know that 60 minutes today is not the 45 minutes of in the last go around. 45 minutes of last go around is still 45 minutes of this go around. Having said that, some of us do extended psychotherapy, and you should, as much as possible, code what you do. But make sure there's reason and documentation that supports that particular activity. Now, what are we looking at? I believe that there's going to be a new extended psychotherapy session code that may not be found in the traditional way. We've been debating this issue within CMS, to me at AMA, and since we're bound by confidential agreement, I can't tell you what's going on. But I do believe that by the end of the calendar year, we might have a solution for those of you who do work with complex cases, attachment, borderline cases that require extended interventions, or for some reason the patient's coming from far away. So I believe that we'll be in a position to have assistance for you in the very near future. All right, let me tell you a little bit about telehealth medicine. All right, in fact, I was talking to my daughter about this yesterday, and that is that this is the way for the future, especially for those of us that work with individuals that have difficulties with transportation or geographically isolated, and maybe in other parts of the state. Critical that you appreciate there has to be a live video conference, and that, if you will, that live video conference needs to have security. So there was we did actually a workshop at APA Hawaii where that was debated, and the issue of, for example, is Skype fit the criteria of secure? The answer is no. So theoretically, the fees may be minimal, but it does give you the opportunity. You must use an audio and video feed. You must have a professional shortage. For example, there's rural. It could originate from any number of locations. The obvious one is your office. And the assumption is that it's actually same as face-to-face service. At this particular time, individual psychotherapy and the diagnostic interview do qualify for telehealth services. So in essence, you do not have to see the patient face-to-face in person, just through this electronic secure means. And I encourage you to look at the interesting article by Dr. Luxton in Psychological Services and the recent APA guidelines for the practice of telepsychology. They're philosophical, ethical, and empirical. They're well written and bears further discussion and getting acquainted with them. So, to summarize at this point, this is what we have. We have basically 3 columns, and we're working this evening primarily on the psychiatric. DSM is the diagnosis. The interview is 90791. Testing we'll talk about next go round is 101, and psychotherapy you see as well below. In essence, what we have is the psychiatric model. We have interview that links to testing, and testing leads to intervention. This is important that you consider that one leads to the other. I do appreciate the fact that for many people who do psychotherapy, it's not unusual to link from 90791 right to 90834, and that's fine because that's obviously the standard of care for many practitioners. However, do always think that one results or links to the other. As far as the modifiers, I just throw this slide in just to alert you that sometimes you have unusual services, or you have reduced service. For example, you have a 45-minute session, the patient walks out, gets upset, and you have to code it as 52. One of the issues, and I encourage you to be aware of this, that some of us work with psychiatrists or other professionals like social workers, and when that happens, it's very often that a company will deny the use of 2 mental health professionals providing services in the same day, even though one could be medication management and the other one could be psychotherapy. Be aware of that limitation, and if that's present, you may want to consider using the code 59 and explaining why two services were done by mental health professionals at this point. A quick side comment regarding CPT by report. It is my feeling that either you have a report for every CPT code that you bill, or for that matter, that you have within one large report, for example, multiple levels, each section, or if you will, a section should describe a particular CPT code. And the reason for that is not necessarily for clinical purposes, but for auditing purposes. Let me take a few minutes of your important time this evening to address the issue of conceptual time. What's time? First of all, time is what the professional does, not what the patient does. Interview and assessment codes can be limited or extended. Intervention codes at this point, and I unfortunately have 15, there is no 15-minute code, at least for psychotherapy. There is for health and behavior. So there's different forms of time. But critically appreciate it's not what the patient does, it's what the professional does. However, it does involve communicating with others and following up with the patient. Non-face-to-face time sometimes is not included in the measurement of bill time, but has been included in calculated total work of service during the survey process. In other words, we're assuming that after the psychotherapy, you will then maybe call or talk to the secretary or whatever the case is. That is included in the actual survey. A unit of time is obtained when the midpoint has passed. I've already been through that. That if you do not have 16 minutes, you do not have the experience of psychotherapy. All right? Face-to-face, unless otherwise stated, and the unit of time when the midpoint is passed. Do not count time twice. And finally, when multiple days are involved, time is not reset with each, and you do not create a new hour. If a continuous service is provided, for example, as a crisis, report all units as performed on the date that the service was started. So in other words, if you start psychotherapy crisis on Friday and it spills over into Saturday morning, then at that point you would put all your activities on if you will, Friday. If, on the other hand, you start again with a different variation of the theme of the crisis on Saturday, it behooves you to consider a new crisis code on that second day. What's non-face-to-face time? You can see the information contained in this very busy slide, including communication and so forth, so on. This is a very complex slide. It has a lot of narrative, but also gives you a very clear definition of what's non-face-to-face that is often included in the psychotherapeutic experience. And one more time, here we go. Here's what 16 minutes might look like. Now, let's talk about how you document time. I do not believe that elapsed time is any longer accepted. In fact, if you haven't done elapsed times, skip it, don't worry about it. Let's go right to start and stop times. If you start seeing a patient 101 and you finish at 148, put that down. You may want to have backups for all this. Your scheduling system, testing sheet, any kind of information that could provide some backup to the fact that you actually provided the service. So for example, we do not throw away our schedule books, or for that matter, our electronic books, simply because this provides a backup to the fact that we did provide that service, and we find that in two different locations, the record itself and the scheduling sheet. A few issues regarding time, and this is just a very generic idea because we don't know for a fact, but therapy for individual is 1 unit, for group could be 8 units. Interview, most likely it looks like 1 to 3. So can you do an interview that's 4 or 5 hours? Yes, but you automatically become an outlier, and that decreases the increases the likelihood of an audit. All right, so let's kind of bring it all together. What do we have here? This is a new paradigm. Psychotherapy is different in many ways. Now we have a paradigm that includes if you will, three levels. If you just to put it in simple terms, standard psychotherapy, more complex psychotherapy, and crisis psychotherapy. That's one issue. First of all, we have 30, 45, and 60 minutes. We probably will have 90 minutes before long. Also, keep in mind that unlike the old 90801, the new psychiatric interview code allows you to do collateral interviews over many days with more than one person. This is a very robust code relative to what we historically have. So in essence, what we have now is an entirely different view of how psychotherapy works. It really mirrors much more the, if you will, the E&M codes where you have different levels. It provides a more robustness, and in some ways, you might even argue that it might provide some reimbursement opportunities. But theoretically, it's intended to capture modern-day psychotherapy, much more so than the prior codes that were historically available. Now, in terms of resources, I provided several available to you. They're found in the different slides that I'm showing you. And I do point out that in my website, psychologycoding.com, you can find different forms that I use for psychiatric interview and in psychotherapy. These by no means the perfect ones, but it might be a way for you to start some basic information of how to proceed in developing your own forms that apply to your practice parameters. Having said that, you can find more information at the American Medical Association bookstore, and of course the contact information for the American Psychological Association, Association for the Advancement of Psychotherapy, and of course some of the other things that I've mentioned to you before, including the so-called psychologycoding.com, which we do our very best to keep up on a regular basis. This presentation will be available on YouTube sometime next week. I sincerely apologize for us taking as long as we did. We actually did a dry run a couple of days ago, and we thought we had it done. We typically do this at the university, and we are not in a position to do so because of unforeseen circumstances that one day maybe I'll explain. But at this particular juncture, we believe that we've provided at least enough information to get you rolling. And with that in mind, I'll put this terrible picture of myself and say thank you very much for your attendance. And if I can figure out how to work on this, I'll open up chat, or I should say questions and answers. So what questions? Oh, it says it's disabled. So maybe we can go to chat, and if you have questions and I can do the questions this way, we'll attend to them. And if not, please send them to me at at uncw.com, and we'll address them at that point. So I'm not sure if we have the opportunity to ask questions, but let's see if we can try to do so. I'm not sure if we do. Well, with that in mind, it looks like we do not have the enable function, or at least I don't have the capacity to do so, so I'll call it a day at this particular juncture. I appreciate you very much attending this evening's presentation. We will make this available on YouTube, as I mentioned, and if you have any questions, I prefer that you send them to me by email at puente@uncw.edu, and remember the psychologycoding.com website, which has a lot of this information and more. So thank you very much for you participating, and apologies one more time for the difficulties that we have technically, and look forward to the next presentation on testing. We may do one after that on HMB. I'm not sure if we'll have the opportunity to include that at the next one, but look forward to providing that. Thank you, and have a good evening.